Thank you very much for the introduction. The topic this morning is about difficult decisions. The topic today is about difficult decisions in coronary intervention patients. First of all, protected percutaneous coronary intervention in complex high-risk cases is a common occurrence now because many patients are elderly. They may have had bypass or angioplasty years ago, and they may present again with coronary disease, which is complex. The extent and severity of coronary ischemia can remain a major determinant of mortality, and therefore medical treatment alone in high-risk cases is not enough, and especially when the ischemic burden is large. The benefit of revascularization is directly proportional to the extent of ischemia, and completeness of revascularization has got implications regarding prognostic benefit. So with increasing life expectancy, extensive prevalence of coronary risk factors, number of patients presenting at an advanced age and high-risk clinical presentation is becoming more common. Therefore, catering for these patients become very important. And as different units in the island and also internationally in developing countries accumulate experience in these sort of cases, the requirement of equipment, complex equipment, and also training, and also readiness to tackle these cases become an important issue. This has resulted in the birth of a new subspecialty in interventional cardiology called complex high-risk indicated patients, or CHIP as it's called commonly in some countries in Asia, for interventions. So the high-risk complex case would include patients with comorbidities like advanced age, frailty, chronic obstructive pulmonary disease, and patients' ability to withstand the procedure is an important issue when discussing about doing intervention. And sometimes anatomy could be really difficult, like calcification or CTO, and the last surviving vessel or vein graft that have degenerated determines the complexity of the intervention. The hemodynamics may not be favorable, and you may have poor left ventricular function and associated valve disease, which can determine the hemodynamic stability during the procedure. So in the complex cases, we're going to inject contrast, we're going to use balloon dilatation, atherectomy devices are sometimes used, and stent manipulation transiently can disturb the blood flow to the target vessel, which can result in negative inotropic effect and potentially give rise to problems, which has to be anticipated. And the high-risk patient has limited ability to withstand the hemodynamic effect of dysrhythmia or ischemia reperfusion injury or no reflow associated with the PCI. And this type of patient may have significantly low cardiovascular reserve and increasingly susceptible to post-ischemic stunning. So these are potential problems. On this slide, which is quite a busy slide, it summarizes the issues regarding the patient comorbidity, age more than 70, frailty, previous history of CVA or diabetes mellitus, chronic kidney disease, peripheral vascular disease, chronic lung disease, and severe aortic stenosis in some cases. Patient may present in a situation of STEMI or an ACS with unstable hemodynamics, dysrhythmia, and refractory angina. There may be mechanical complication of an acute MI like a VSD or ruptured pulmonary muscle, cardiac shock, congestive cardiac failure, coronary intervention after resuscitation, after cardiac arrest, and severe left ventricular dysfunction. And complex anatomy, as we have discussed, mentioned earlier, distal left main bifurcation, multiple vessel disease, degeneration of vein graft, last remaining coronary conduit vessel, and the score associated with the CTO or the syntax score more than 33, where the ischemic burden is very high. And adverse hemodynamics when the low cardiac output, for example, less than 2.2 liters per minute per meter square, elevated pulmonary wedge pressure, more than 15 millimeters of mercury, or elevated pulmonary pressure, mean more than 50, carries a higher risk during intervention. So some hospitals actually will specialize in that sort of cases, and therefore the team has to be ready. You will need at least 2 qualified physicians who can do complex cases and also offer a service where you have technical support, ICU and cath lab nurses, round-the-clock emergency service, and also cardiothoracic surgery backup because of the importance if things go wrong, and intensive care physicians and nurses who are trained in handling these high-risk cardiac patients. Also important to bear in mind that if you're going to have that sort of service around the clock, the economic aspect is important. And the physician who's going to do those cases will be somebody who is used to doing complex cases and skilled in handling complications as well, and also working in conjunction with the anesthetist, ICU physician, and the cardiac surgeons, and be actually conversant with using complex stenting strategies, even CTO antegrade, or in some countries retrograde. And also knowledge of the imaging like IVUS is important, and also if in case you have perforation, access to the devices to bail out the problem, like basically the coated stents, and also device embolization and entrapment and retrieval devices that may have to be used in case of complications. So planning of the procedure is important, and also the heart team involving the cardiac surgeon, the interventionist, the anesthetist, and also the referring doctor should all be involved in making a prudent decision about undergoing complex cases where if things go wrong, the patient may be at extremely high risk of mortality before embarking in that sort of cases. And also if somebody's had previous angioplasty or bypass, how many grafts were done, and what was the potential difficulties that was faced in the first time, what sort of guide catheter, whether the support was poor, or whether previously CTO has been tried, and with what equipment and why it failed. All these are important information that should be in the file, or at least asked for if the patient had intervention done in another hospital. And also the pros and cons of the procedure have to be explained in detail to the patient and the relatives, and informed consent obtained. It's important to also think about hemodynamic support devices that are available in the hospital before embarking on the case, and also if things go wrong, do we have the bailout devices, and if not, should we be undertaking these procedures? So patients who have support devices for hemodynamics stabilize the patient during the procedure, and we will mention some of the devices in the slides coming up. And the various support devices at different levels of backup, which sometimes are not always available in our hospital. First of all, intra-aortic balloon pump, which is commonly available and widely used. You need a small access size compared to other devices, ease of percutaneous implantation, and readily available in many cath labs, and therefore very useful. But important to bear in mind that the increase in your cardiac output with the balloon pump is about 0.5 liters per minute, which is not a lot, but can be very useful in STEMI or non-STEMI while you're doing a case in an emergency situation. Disadvantage, if you have dysarrhythmia, the support may not be as reliable, and occasionally there could be complications of hemolysis, aortic dissection, stroke or infection if left for a long time. And although there's lots of experience with intra-aortic balloon pump, it provides minimal hemodynamic support. And in the literature you will see that it may not be adequate for severe forms of cardiogenic shock. And intra-aortic balloon pump has been studied extensively and has not reduced mortality, unfortunately, in patients with cardiogenic shock or high-risk PCI, except in the setting of STEMI with patients treated with fibrinolysis, for example, where the evidence is stronger. But sometimes this is the only thing we have, and therefore we have to use it because we don't have other devices that are now found to be extremely useful, including the impeller device, which we don't have in Mauritius yet, but it's actually hopefully going to come up in the coming year or in the next 2 years. Impella basically is a rotary blood pump microaxial that is inserted into the left ventricle percutaneously from the femoral artery, and that expels blood directly from the left ventricle to the aorta, and it decreases therefore the end diastolic pressure, the end diastolic volume, and also the end systolic volume, and therefore helps to offload the heart. It increases cardiac output and coronary perfusion. And the different types, these Impella LP 2.5, which increases output up to 2.5 liters per minute, which is much more than a balloon pump. And the Impella CP, which increases up to 4 liters. And Impella 5, which is a bigger device, up to 5 liters per minute. But the 5 device has to be put in surgically to cut down, whereas the other one are percutaneous and is done by the interventional cardiologist. Currently, the FDA approves Impella device in patients with coronary shock after MI or bypass surgery, and this is very useful. And a few years ago, Dr. Lawton was in Mauritius and presented a number of cases of coronary shock successfully angioplasty in that sort of situation. For those of you who were at that meeting, it showed an excellent example of how useful this device can be in bailing out cases high risk and successfully stenting patients. There are a number of advantages: easy to use and augment the cardiac output by up to 2.5 to 5 liters per minute, and does not require stable cardiac rhythm. So even cardiac arrhythmia, the support is much more reliable. Disadvantages: it's not available everywhere. It requires 12 to 14 French access or surgical access for the Impella 5. It is non-pulsatile flow, and the risk of displacement and access site complication increases of atherosclerosis, stroke, and infection reported in the literature. But extremely useful, of course, in a difficult situation. Another way to support the heart is ECMO, extracorporeal life support. Extracorporeal life support, formerly known as extracorporeal membrane oxygenation, ECMO. It's a modified heart-lung machine that can be implanted percutaneously. It has a venous cannula that is placed via the right femoral vein to drain the right atrium, and an arterial cannula which is placed in the iliac artery or the descending artery. And therefore it acts like a heart-lung machine that can get blood in and out of the system and get oxygenated externally, and therefore help to improve your circulation and provides considerable hemodynamic support. But it does have a significant increase in afterload that in turn intensify left ventricular wall stress, and it may be sometimes deleterious in an already compromised left ventricle. Having said that, ECMO is used widely in many places in the world, and also extremely useful in this sort of situation of where you have a need for extra support to support the heart. So it augments your cardiac output by more than 4.5 liters per minute and does not require stable cardiac rhythm, and can be used to support the circulation up to a number of weeks. Disadvantages: not always available, non-pulsatile flow, and possible poor perfusion of the coronaries and the cerebral circulation, and may require concomitant use of intra-aortic balloon pump, which is interesting and also important to note that if you have somebody on an ECMO sort of support, you may need balloon at the same time in a difficult situation to support the heart. And access site complication like limb ischemia, access site complication and limb ischemia and systemic inflammation, renal failure, systemic embolization, stroke and infection, all these are recognized potential complications. And the need for perfusion is, of course, for this sort of support is important. We did actually have ECMO in the hospital in the cardiac center a few years ago, and we did actually cases of acute myocardial infarction as well, but at the moment we don't have the facility. But there is actually a plan of reintroducing this to help in difficult cases. In the literature, you also hear about tandem heart, and also widely used in a number of big centers worldwide, not available in Mauritius. Just to mention that it is a percutaneous ventricular assist device which works without the need for external oxygenator or heat exchanger. There's an inflow cannula that is placed in the left atrium via transeptal puncture from the right femoral vein, and an outflow cannula which is implanted at the level of the aortic bifurcation via the right femoral artery. So the device pumps, cycles the oxygenated blood from the left atrium to the femoral artery and provides up to 4 liters per minute of cardiac output. And this device indirectly offloads the left heart, reduces cardiac filling pressures, and therefore useful clinically for that reason, and reduces myocardial oxygen demand as well. Again, sometimes you may have paradoxical increase in myocardial oxygen demand due to the rise in the afterload with cardiogenic shock with severe left ventricular impairment. In such cases scenario, additional left ventricular unloading, like intra-aortic balloon pump or impeller, may be necessary. Again, number of advantages and potential disadvantages. It can augment the cardiac output by up to 5 to 45 liters, support the circulation for up to 2 weeks, and does not require stable cardiac rhythm. Disadvantage, the requirement for transeptal puncture and difficult to use in emergencies. And you may sometimes have right atrial displacement of the cannula from the left atrium, which can lead to profound desaturation suddenly, and something that is watched out for in big centers where they use it. Access complication, again, stroke, infection, and hemolysis, and atherosclerosis are potential complications to watch out for. This is a summary slide showing the comparison of the various mechanical support. Intra-aortic balloon pump we have and use in Mauritius, but it does have its limits. Because you rely on the heart rhythm, and also your cardiac output increase is limited up to 0.5 liters per minute. Impeller, which gives you a better improvement of cardiac output, can be used for longer, for up to 7 days, and also the ease of access and potentially lots of benefit by reducing your left ventricular diastolic pressure even more, and also reduction in myocardial oxygen demand and your afterload. The tandem heart provides even better hemodynamics, but not available in our country. And same thing that applies to ECMO, but ECMO, hopefully, it was there in the center a few years ago, and then there is actually a demand to bring it back as well because of the potential benefits in high-risk cases. And also important post-procedure care. Once you've done the angioplasty and your patient is back on the ICU, the nursing staff, they need to be familiar with the higher risk and also the importance of hemodynamic monitoring, and also alerting the physician if there is any problem. And the need for anticoagulation, checking other parameters like lactate, and if you suspect infection, things like calcitonin, blood culture, all that is important. And also recognizing the importance that sometimes the device may migrate, can move, there could be bleeding, there could be limb ischemia, for example, with balloon pump. You have to watch the foot pulse because many of these patients may have peripheral vascular disease, may be undiagnosed from before. But the size of the femoral artery is also important. You need a size of more than 4 millimeters for the femoral artery for a balloon pump. Obviously, for the bigger devices like impeller and others, the size of the artery has to be much bigger. Just a few words regarding post-procedure care. The weaning off of the devices, like for balloon pump, which we're all familiar with, reducing from 1 to 1, 1 to 2 for 10 minutes, then 1 to 3 for 10 minutes. And then if the patient is still stable, then you can decide about the device can be removed or not. For impeller device, again, there is a protocol as listed here about reducing the level of support and then assessing the patient before decision is made to remove the device. For balloon pump, it's interesting and also important maybe to highlight that in the literature they do suggest that once you're weaning off your balloon pump, you've come from 1 to 1, 1 to 2, 1 to 3 over several hours, and the patient is still stable for 3 hours, hemodynamics on 1:3, then the device can be set back at 1 to 1 and the heparin infusion is stopped. And once your PTT is low, less than 50 seconds, then the device can be removed. reason why they suggest this is if you are on 1, 2, 3 and you're not on anticoagulants, the risk of thrombus formation is higher. But if you're on 1 to 1, the risk of thrombus on the balloon is much less. And impeller should be weaned over hours again with reduction of level of support in 2 levels every 2 to 3 hours. But because we don't have this device here, we won't go into the details. So in the guidelines, the use of hemodynamic support device in high-risk cases is highlighted, and the level of evidence sometimes 2A and useful, and also highlighted in what situation you would use them. And for example, the use of balloon pump in STEMI with cryogenic shock when pharmacotherapy is not enough on its own has been found to be useful and also beneficial in changing the outcome. And alternative LV assist device for circulatory support can be considered in patients who are refractory, who have refractory cryogenic shock. And patients who are having PCI with high-risk features, for example, unprotected last remaining conduit, PCI, cryogenic shock, or PCI for a vessel that supplies a large territory in a background of severely depressed left ventricular function, these sort of cases will benefit from hemodynamic support devices for sure. And in unstable angina or non-STEMI, again, reasonable in these situations if you have a severe ischemia to consider use of this device, especially when your hemodynamics is not great. And found to be useful, and also in some situations, like in our units in Mauritius, we do not have many other options. So the current evidence shows that complex high-risk cases need an advanced level of care and proper planning, and also the heart team has to look at all the aspects, including the counseling of the family, and also what can potentially happen, what can go wrong, what is the risk of mortality, and then what are the arrangements for bailout if the patient doesn't do well. And although it's well known that revascularization appears to be beneficial in these high-risk cases, it must be borne in mind that the procedure itself has a high level of risk, and also the cost of the procedure could be quite high if you're going to use these support devices. So it needs to be evaluated in major randomized trials, which is something that may be very difficult to do, except maybe if it's done worldwide with a registry to look at those aspects which help in decision making, and then coming up with guidelines to know what to use in various situations. So in conclusion, patients with elective high-risk PCI should be transferred to high-volume centers where operators are used to doing complex cases, where you have all the support that is available in the service, including balloon pump, ECMO, and also an ICU setup and cardiothoracic backup as well. And most of the devices that we use, the balloon pump obviously is the most common. The femoral bypass was used in the past, and now ECMO is a modification of that and is extremely useful. And the role of impeller, which is been shown to be extremely useful in high-risk cases. So I'll stop here because this is just to show you an overview of what potentially is available. And also in high-risk cases, decision-making should not be done by only one person, but by a heart team, and also involving the family and also involving the referring physician so that everybody is on the same wavelength. And because of medical legal implications as well about doing ad hoc cases, this is not recommended for sure. And the need for a committee, for example, to look at the case and discussing it in detail before asking the patient to consent for this sort of procedure. Thank you very much.